Dr. Julia Liu is a faculty gastroenterologist at the University of Alberta, with a research interest in endoscopic treatment of gastroesophageal reflux disease. Upon completing her medical degree at the University of Toronto, she continued her training at the Mayo Clinic and Harvard University. When a doctor sees this bleeding, I hear that people use something known as endoscopy to investigate where the bleed is coming from. Would you mind discussing that?
Sure. Endoscopy is a set of equipments that the gastroenterologists use. What these equipments are essentially a lighted camera attached to the end of a fiber optic instrument. And with this particular instrument, we're able to see essentially most of the gastrointestinal tract and looking for sources of bleeding. The most commonly performed procedures are gastroscopy, which is to look at the esophagus, stomach, and first part of the small bowel, and colonoscopy, which is to look at the entire length of the colon and the end of the small bowel. There are also something called enteroscopy, which is a more prolonged test where we look through the entire length of the small bowel, because your small bowel is almost 30 feet in length. That is a much more prolonged procedure, and it's usually only performed after the gastroscopy and the colonoscopy evaluations have been performed.
Are these procedures dangerous?
These procedures can have complications associated with them. We always highlight to the patients the most likely complication is bleeding. And the bleeding is a result of interventions that we do. For instance, if we see a polyp on colonoscopy or on the gastroscopy and we decide to remove those lesions, then there is a fixed rate of bleeding associated with that. And however, most of the time the bleeding rate is no more than 1% for a given procedure. The second complication we always quote to the patient is perforation, which means causing a tear somewhere in the gut. And the reason for that is as we're passing the instrument, it may inadvertently go into spaces that we did not intend to go into. And the rate of perforation is a combination of factors, including what the underlying disease of the patient is, and also what are the lesions that we are evaluating and we're treating. So, for instance, for colonoscopy, if the patients have previous surgery, if they have ongoing ischemia or severe colitis, they're at an increased risk for perforation or tear in the colon. Or if we're doing a procedure such as polypectomy, which means removal of a polyp, that can also result in perforation or tear. So these are all the things that could potentially happen. However, perforation occurs less than 1 in 1,000 in a usual endoscopy center. So these are very infrequent occurrences. However, they are serious, and we do discuss those with the patient. And finally, there is the infection risk that we always quote to patients as well. This is related to whether the instrument is sterilized completely. And again, the risk there is a function of how many procedures are performed in the unit and how well the sterilization occurs. But again, overall, the risk is less than 1 in 1,000. And there are some other procedure-related or procedure-specific complications. For instance, for the gastroscopy, the patients could potentially have pneumonia or aspiration pneumonia as a complication. And that can occur when the patient have aspirated their gastric content or even saliva during the procedure. We try to optimize the chance of risk for the patient by asking the patient not eat or drink anything for at least 4 hours. Most of the time we ask them 8 hours in advance. However, that can still occur. The complications can still occur. So these are not guarantees that they will not have the complication. So the aspiration pneumonia is a commonly quoted side effect or complication of the procedure. Finally, there are other risks such as missed lesions, which means even in our best intentions, in about 5% of the times we will miss something that if we do a second procedure it will be detected. And that's been shown for colonoscopy as well as gastroscopy. And this is related to the duration of the procedure, how carefully you inspect the areas, and it's almost an inevitable risk of the procedure that we miss something.
Okay. Are there any advances in endoscopy in relation to finding out where bleeds are?
Yeah, so there is this new advance in the past decade or so called capsule endoscopy, where a patient swallows a capsule and it contains a camera in it, and the camera can take pictures throughout the gut. And what we have been able to do is use that to detect lesions mostly in the small bowel, because enteroscopy is such a prolonged procedure to undergo that we usually like the patient to have had an identification of approximate location of the bleeding site before we start the enteroscopy, and that's usually accomplished by the capsule endoscopy. So that's much less invasive because there is no instruments attached to it. It's a wireless transmission system that the patients swallow, and it's the size of a vitamin pill. So that's been the most interesting development in the past decade.
Okay. And I've also heard that endoscopy can sometimes be used to treat bleeding.
Yes. So nowadays, most of the gastrointestinal bleeding are treated endoscopically. In rare occasions, we do have failures, particularly for very severe GI bleeding, we call it. So if the patient is vomiting large amount of blood and the bleeding is very brisk, we may not be able to control that, but by far majority of the bleeding, over 95% of the bleeding, are now controlled endoscopically. And there have been a number of advances in this field in terms of how we can best treat these lesions. So we have now a range of endoscopic modalities to treat bleeding, including we can inject epinephrine, which is a agent that constricts the blood vessels or make the blood vessels tighten down. We also have thermocoagulation, so essentially a heating mode that can cause the blood vessels to be cauterized. And we also have now mechanical modalities such as a clip. So the function of the clip is to compress the blood vessel, and that will accomplish the goal of controlling the bleeding. And there are some new exciting developments, including fibrin glue type medication, or a spray where you can actually spray on the agent and it causes a clot to form over the area. So those are all research agents that are in the pipeline that we look forward to having in the next 5 to 10 years.
Okay. Well, thank you very much for answering some of my questions on endoscopy. Have a great afternoon.
You too. Thank you.